think that it helps everybody get a different. So the topic, kind of continuing with the neurology module this month, which is very kind of pertinent to all of our practice, I think, on a very regular basis, something that we are constantly seeing, what, if any, additional care these patients need. And it can sometimes be very challenging if someone's symptoms do not kind of align with what we're anticipating. If their symptoms are kind of waxing and waning or somewhat different than we would anticipate. So at least for now, let's get started. We can cover some of these questions and then kind of go from there. Okay. Let me see. Make sure I can get here. Okay. Pull up the chat here. All right. Can everybody see the questions? Yep. Yes. Perfect. Thank you. All right. So this question to kind of start us off with some stroke syndromes, stroke presentation. We have a 65-year-old presents to the emergency department concerned about a stroke. He comes in with his daughter, who saw him 4 days ago and he was normal. On CT scan, a non-contrasted CT scan, you see a hypoattenuation in the right frontal cortex. Knowing that information, what would you anticipate his physical findings would be on examination? We're losing some people.
If you want, you can put your answer in the chat box.
Yeah, that may be easier. We are having some latency issues. Good. I think an important part of this question is the finding on CT scan is only in the right frontal cortex. You don't see any additional imaging findings on CT, at least. And I saw how well everybody did on their questions last week, so I made these ones a little bit more difficult.
In the brain function, the front space, the front cortex, perfect for our left and hand in the parietal. This in the brain is in the frontal cortex, so I think this is effect for the left, and in the hip, in the right side, it's not a dominant hemisphere. So this effect for the left and yeah.
Oh, I'm sorry. Your microphone is cutting out pretty badly. So it's making it challenging for us to hear and understand.
Thì cái trả lời là
I choose D.
Answer D.
choose D because this is D. Yeah.
Got it. Okay. Perfect. Good. So good. I'm glad that this question, at least from what I heard, although like I said, the audio is a little bit challenging right now. I think from what my understanding was of your answer, so we can see at least on the imaging here that this is only in the right frontal cortex. So of the findings that, or the kind of innervations and the control from the front, and what arterial distribution that would be and what we would anticipate there. So let's see. So the answer for this question, I would say, is D, which we had spoken about just a moment ago. So in the frontal cortex, the only motor findings that we would anticipate seeing, and if they were only leg and three findings, that we would anticipate that to be in the right or in the cerebral cortex, or in the frontal cortex, excuse me. The middle cerebral artery supplying the temporal lobe, parietal lobe, and some of the additional internal capsule and the kind of deep posterior aspect of the frontal lobe would tip into with additional substantial findings. So we would be seeing distributions in the of hypoattenuation within those arterial distributions as well. So if it's limited to the those findings are most typically seen in the anterior cerebral artery distribution rather than the middle cerebral artery distribution. And an MCA, or middle cerebral artery distribution stroke, we would anticipate seeing some additional findings, such as upper extremity, such as arm weakness, potentially aphasia, depending on if it's the dominant or non-dominant hemisphere. And with the ataxia, nystagmens, and dysarthria symptoms, those symptoms are most commonly seen in posterior circulation strokes. So the PCA or basilar artery distributions. And then hemianopsia as a kind of isolated finding is concerning for a stroke and infarction, specifically within the posterior cerebral artery distribution, and specifically branches supplying solely the occipital lobe. Other findings in the frontal cortex you would not anticipate seeing there. But occasionally, in rare circumstances, branches of the middle cerebral artery may have isolated sensory and motor findings, but in the frontal cortex, we would anticipate that being an anterior cerebral artery distribution. And then the anterior cerebral artery distribution is predominantly lower extremity symptoms. So that would be kind of waist and down is where we would anticipate seeing those symptoms. So. All right. Questions on this one? I know that some of these are certainly going to be, I think, pretty challenging, which I think, like I had said before, and I like to say, I think that the opportunity for learning is much higher in those circumstances. So. Okay, let's go on to the next question. Okay, in this scenario, we have a 55-year-old woman with a history of diabetes and hypertension coming in with left arm weakness approximately 2 hours before arrival. On exam, she has a left pronator. To a different question?
Yes.
Perfect.
We think middle cerebral artery. Yeah.
Good.
MCA.
Perfect. Good. Which is, so left-sided symptoms, predominantly in the arm. So then we have, additionally, we have sensation and speech are intact. So we have the patient weakness, okay, that is by pronator drift and 2 out of 5 strength compared to the right side. And then in this question, we are also seeing sensation and speech being intact. So in this case, we know that it's not going to be on. It's not going to be on the left. So we know immediately that part is wrong. It's involving strength, predominantly strength. So it's very unlikely to be related to the cerebellum. And then we'd have to decide between the right frontal and right parietal lobe. In the frontal lobe, because the deficits that you see in that area are more likely to be isolated motor, so isolated strength deficits, and very rarely will you see very rarely will you see sensory deficits in that area as well. In addition, because of the motor and sensory homunculi and the distributions of those symptoms. In the parietal lobe, strokes in that area almost exclusively cause sensory and motor deficits. And let me see if I can pull up a let me see. Okay. Trying to see if I can pull up a photo here so that we can see. Okay. Can we? Oh man, now I've done it. Can we see the screen here? Can you put it in the chat because I've removed my, oh, there we go. Okay. Can we see the screen?
Yes.
Yes, perfect. Okay.
Làm gì mà ngồi nói chuyện online vậy?
So we can see here, based on the distributions, compared to the frontal and parietal lobes, if the parietal lobe, which is located in this area, if this is affected by a stroke, we would anticipate seeing sensory involvement here, compared to an isolated frontal stroke, which is in this area. And I apologize, I did not pull up the right photo for this to see the actual distribution. I'll send this out in an email later today about the sensory and motor distributions within the brain, because I also don't think that I have that in my that specific slide in my presentation. So we will pull that one up at a different point. But let's see. I'll send out a clarification on that one. I apologize for that. Okay, let's move. Okay. Okay, let's see the next question. A 75-year-old man presents to the emergency department with right arm ataxia and right leg weakness. Which of the following would most likely provide the diagnosis or the underlying etiology of this patient's stroke? So we have right arm ataxia and right leg weakness. Are not likely to be caused by the same stroke. Is that that's what you're saying? Perfect. I completely agree with that, which is very challenging. So if we were looking for possible metastases or other underlying causes of an ischemic stroke, a brain MRI